Entropion refers to a turning inward of the eyelid margin. So the eyelid margin is normally a square platform. The eyelashes come out from the front part of that platform, and in entropion, that whole complex rotates in. So it's not just that the eyelashes are misdirected or turned the wrong way. We call that trichiasis. Entropion is actually a turning in of the eyelid margin. It happens most often in the lower eyelid, but cases that are due to scarring can involve the upper eyelid as well. And patients with entropion present with a lot of irritation. As you can imagine, the surface of the eye is normally used to having this nice, smooth mucous membrane blinking, right? That's what lines the backside of the eyelid, is the conjunctiva. But in the case of entropion, the eyelashes are rubbing, the keratinized skin from your lower, or in some cases your upper eyelid, can be rubbing on the surface of the eye, and this causes a lot of irritation. That can give you redness and mucus discharge and blurred vision, and it's really bothersome for patients. As I alluded to earlier, there are several different causes for entropion. Probably the most common that we see in our practice is involutional, again meaning age-related. And this usually involves the lower eyelid. It happens because you can develop laxity horizontally. As we get older, your eyelid becomes more stretchy. You can also have the muscle that pulls the eyelid down or provides some vertical support stretch out or even disinsert. And the muscle that is responsible for blinking and closing the eyes can sometimes shift up a little bit. We call that an overriding orbicularis. And so all three of those things together, horizontal instability, vertical instability, and a muscle that wants to roll things in, can contribute to entropion. Now, in terms of ways of managing involutional entropion, there are some temporizing things that we can do. There are some things that you can do at home if you're waiting for your consult, and that includes, placing a piece of tape. So you press the tape onto your eyelid here, and you pull your eyelid down, press the tape back onto your cheek here. That just helps to keep the eyelid rotated out. Of course, that's not a perfect solution. It's certainly not a long-term solution, and you need to reapply the tape every day. So you want to use a tape that's not going to be irritating. Even a steri strip would be a great option, but it can help make your eye more comfortable in the short term. The other short-term solution is using a little bit of neurotoxin, like Botox. Now that works by doing 2 small injections into the pretarsal orbicularis. This is the part of the muscle that blinks and closes your eyes that's responsible for rolling in that eyelid margin. So by making it weaker, which is what Botox does, it lets it come and rotate back out so that it's not scratching and rubbing on the surface of the eye. But ultimately, most patients with involutional entropion require surgery. Now, surgery, again, is individualized based on exactly what is going on with your eyelid, but in general often involves tightening the eyelid horizontally and strengthening the insertion of the muscle that pulls the eyelid down so that you reestablish the horizontal and the vertical stability. Sometimes we also remove small areas of the muscle to make it less strong if the overriding muscle is really a large component of what's causing your eyelid to roll in. Now, in addition to involutional entropion, there can also be issues with the eyelid rolls in because of scar tissue. Some of these cases are due to inflammatory conditions like autoimmune conditions. Ocular cicatricial pemphigoid would be one of these. And in this case, the back side of the eyelid, either the lower or the upper, becomes scarred and contracts. And so instead of this instability and overriding muscle rolling it in like you have in involutional entropion, in cicatricial cases, you actually have the back side of the eyelid pulling the eyelid margin in. These are much more difficult to treat and more nuanced in terms of how we approach them. Sometimes we will replace what is along the edge of the eyelid with a graft from your mouth so that what is rolled in is smooth and not irritating the surface of the eye so much. Sometimes we try to rotate the eyelid back out. It really all depends on the individual situation.